Hello, my name is Darby Dyar. I'm a clinical research coordinator with the Department of Physical Medicine and Rehabilitation at Indiana University School of Medicine, and I will be presenting on two assessment options for evaluating negative attributions and related anger in patients with brain injury. To get us started, chronic problems with anger and aggression are typical after a traumatic brain injury. A series of recent studies in the TBI population suggest that anger in response to specific events is often related to how individuals interpret others' actions. So the more intentional, hostile, and blameworthy they judge another's actions to be, the stronger their self-reported anger. Research has found that participants with TBI judge others' actions more negatively than did those without TBI. The relation between these types of judgments and anger is known as the attribution-emotion association. The tendency to disproportionately judge others' actions as negative or more extreme than the norm is referred to as negative attribution bias. In addition to associations with anger, negative attributions have been associated with higher aggression in samples with and without TBI. These discoveries combined have provided an important advancement toward understanding mechanisms related to post-TBI anger and aggression. To further our understanding, there is a need to identify good measures of negative attributions in the TBI population. Currently, there is no standardized clinical measure available to assess negative attribution bias in persons with TBI. To date, only two measures have been used in TBI research to evaluate negative attributions: the UP scenarios and the Ambiguous Intentions Hostility Questionnaire, which we refer to as the AIHQ. To begin to address this, Dr. Neumann and colleagues conducted a study with the objective of comparing construct and predictive validity, readability, and time to administer of these two negative attribution measures in participants with traumatic brain injury. The study enlisted 85 participants with complicated, mild to severe TBI that were a subsample of a larger study on negative attributions that was conducted at the Rehabilitation Hospital of Indiana, as well as a rehabilitation center in Texas. The sample included adults who incurred a TBI at least 6 months prior and who also met the following injury severity criteria: Glasgow Coma Scale score less than 13, post-traumatic amnesia of 24 hours or more, loss of consciousness of 30 minutes or more, or a CT scan showing intracranial abnormality. Participants reported no other neurological disorder, history of major psychiatric disorder, or developmental disability. All participants spoke fluent English and demonstrated adequate comprehension. All participants were administered both the AIHQ and the UP scenarios, and they were also administered the Aggression Questionnaire to measure trait aggression. So next we'll talk a little bit about each of these measures. I'll start off with the measures used to evaluate negative attributions, the AHQ and the UPs. Both measures consist of written scenarios describing situations where characters' actions hypothetically result in an undesirable outcome for the participant. Both measures also contain scenarios in which the character's behaviors are described as benign, hostile, or ambiguous. Additionally, self-reported anger responses and the participant's attributions about the character's behavior are rated for each scenario. Next, I'll discuss each measure in a bit more detail. First, we'll focus on the AIHQ. It is comprised of 15 written scenarios that describe characters' behaviors as intentional, ambiguous, or accidental. There are 5 scenarios per category. The scenarios are read out loud to participants, then they rate whether they perceive the character's behavior towards them as intentional, blameworthy, and then also their own anger response. The Likert scale for intent is a 6-point scale, and blame and anger are rated on a 5-point scale. The AHQ also includes 2 open-ended questions to capture perceived hostility, or in other words, what do you think was the real reason for the character's actions, and hypothetically aggressive responses, what would you do about it? These open-ended questions were scored by 2 independent raters on a Likert scale for degree of perceived hostility: 1, not hostile, accidental, to 5, very hostile or intentional, and how aggressive their anticipated response was: 1, not aggressive, to 5, very aggressive. Here's an example scenario from the AIHQ. The scenario is: someone jumps in front of you on the grocery line and says, "I'm in a rush." So question A, what do you think was the real reason why someone jumped in front of you in line? This question is measuring perceived hostility. Then, did that person jump in front of you on purpose? This question is for scoring perceived intent. How angry would this make you feel? To capture anger. How much would you blame that person for jumping in front of you in line? Capture blame. And lastly, what would you do about it? To capture hypothetically aggressive response. So each scenario is presented like this, read out loud, and then there are 5 questions per scenario for the participant to rate. The EPS is a longer measure. It consists of 21 written scenarios that describe characters' actions that are benign, ambiguous, or hostile. There are 7 scenarios per category. The scenarios are lengthier than in the AHQ. They are always visibly displayed to the participant, and then in addition to text for the participant to read, pre-recorded narrations of the scenarios are played with a neutral tone of voice for participants who demonstrate better auditory comprehension. There are no open-ended questions. Participants rate each scenario on a 9-point Likert scale for how intentional, hostile, or blameworthy they perceive the character's actions to be. And then they additionally rate their anticipated anger in response to the scenario on that same 9-point scale. So here's an example EPS scenario. You are driving on the expressway at a reasonably high rate of speed. You approach an area where traffic merges onto the highway. A car sits at the bottom of the ramp, waiting to merge onto the highway. Initially, there is room for that car to merge in front of you, but the driver hesitates. After hesitating, there is no longer enough room for a safe merge, but the driver pulls into your lane anyway. This forces you to swerve to avoid hitting the car. The driver waves his hand, perhaps acknowledging his part in the incident. It is dusk and your lights are not on. The elderly driver continued on, weaving in and out of lanes. So first question, how angry would you be if this happened to you? 1, not angry at all, 9, extremely angry, to assess the anger response. Participants are then directed to use the scale to indicate the degree to which they think the character did or did not intend their actions to affect them the way they did. 1, unintentional, not on purpose, to 9, intentional, on purpose. And this captures intent. The next question, to capture hostility, use the scale to indicate degree to which you think the person's actions were hostile, defined as mean, aggressive, negative, or not hostile, on a 1 to 9 scale again. And lastly, indicate degree to which you do or do not blame the character in the story for what happened to you. 1, no blame, to 9, total blame, to capture the blame score. So the last measure I'd like to talk about is the Aggression Questionnaire. This is administered to measure trait or overall aggression through items that assess for physical and verbal aggression, as well as anger and hostility. There are 34 statements, and participants rate each statement on a 5-point Likert scale for the extent to which it is characteristic of their own behavior. The Aggression Questionnaire is psychometrically sound and widely used, including in the TBI population. Next, we'll move on to data analysis and results. To evaluate the construct validity of the AHQ and the EPS measures, Spearman rank correlation coefficients were computed to estimate the degree of association between each of the attribution scores and anger for ambiguous only scenarios and all scenarios combined, separately for each measure. To compare construct validity between the AHQ and EPS scenarios, a test for 2 dependent correlations was used to compare their Spearman rank correlations or their attribution anger associations. For the AHQ, associations are mostly moderate, except for the blame-anger association, which was strong with all scenarios combined and ambiguous only scenarios, as well as the hostility-anger association, which was weak when all scenarios were combined. For the EPS, the degrees of association between the negative attributions and anger response were significantly stronger under all configurations. The ability of intent, hostility, and blame scale scores from each measure to predict higher than average trait aggression on the AQ was assessed using receiver operating characteristics analysis. RSC curve plots sensitivity against 1 specificity across the range of all possible cutoff points. And the area under the RSC curve, or the AUC, summarizes the overall predictive accuracy. To compare predictive validity of the AHQ and EPS scenarios, AUCs within each attribution, for example, AHQ intent versus EPS intent, were compared using a non-parametric statistical test. An optimal cutoff point was derived for each of the AHQ and EPS attributions and composite scores to aid in future classification of subjects into either higher than average or lower than average trait aggression on the Aggression Questionnaire. All individual AHQ intent, hostility, and blame scores had sufficient predictive validity in identifying participants with TBI who had higher than average trait aggression. AHQ composite scores also had sufficient predictive validity under both ambiguous-only scenarios and all scenarios. All individual EPS intent, hostility, and blame scores, as well as EPS composite scores, had good predictive validity, except for EPS blame under ambiguous scenarios, which was sufficient. The EPS is more sensitive at correctly identifying someone who truly has above-average aggression. The HQ is better at classifying someone who is not aggressive as not aggressive. Next, we'll discuss administration time and readability of the items within the AHQ and the EPS scenarios. The EPS takes longer to administer. Median scores indicate it took almost 12 minutes longer than the AHQ. Median outcomes from readability statistics deemed the AHQ easy to read and classified it at 5th grade reading level. The EPS was deemed fairly easy and was ranked at a 6th grade reading level. However, the AHQ did have one item that reached a 10th grade level, whereas all EPS items remained below 9th grade. It is also important to consider the scoring demands of the AHQ, as it has 2 open-ended items that require raters to score the responses, whereas all items are self-rated on the EPS. However, the EPS does not evaluate potentially aggressive behavioral responses, which is one of the open-ended items on the AHQ. So this slide just briefly summarizes the data analysis and results. So the first aim of the study was to examine and compare construct validity of the AHQ and EPS assessments. Findings support the construct validity of both measures. Attributions of intent, hostility, and blame were significantly and positively correlated with anchor responses to the scenarios. However, associations were stronger for the EPS. Another aim sought to determine how well the AHQ and EPS attribution scores reflect aggressive traits. Attributions from both measures predicted aggression questionnaire scores. Predictive validity did not strongly differ between the 2 measures. In considering practicality and readability of the measures, it's important to note the EPS administration time. It typically took about 30 minutes to administer, which was an average of 12 minutes longer than the AHQ. Reading demands are higher for the EPS scenarios. There are more sentences per item in the EPS, meaning more reliance on working memory when rating items about the scenario. While there is a need for further validation of both measures in a larger sample, the study offers early support for the use of either instrument in persons with TBI. Skewed perceptions of intent, hostility, and blame are relevant to problems with anger and aggression. Compared with the general population, persons with TBI are more likely to be at greater risk for negatively judging others' behaviors. Negative attributions are typically not assessed in persons with TBI, despite their potentially important role in understanding and treating anger and aggression. One potential way in which assessments of negative attribution bias in the TBI population could help is it could aid in explaining social difficulties that someone with TBI may have that may prevent them from successfully reintegrating into their social groups and communities. While further research is needed, and neither measure currently meets the level of a standardized assessment, they may be used as a supplement to help clinicians understand clients' perceptions of social interactions that may be influencing their behavior. Additionally, scores from these measures may be used to help clinicians assess the likelihood of a client reacting with anger or aggression to perceived negative intent in others, which can help inform treatment recommendations. The AHQ and EPS scenarios are promising tools that can provide information on how clients' anger or aggression is related to and likely distorted by their perception of others' actions. Cut-up scores may be used for targeting specific treatments to increase self-monitoring of perceptions, adopting different perspectives, and regulating emotional and behavioral reactions. And to finish up, here's the paper referenced throughout this presentation. Thank you for your time.